Hello and welcome to the Irish Haematology Oncology Podcast. I'm your host, Eoin Tabb, and in today's episode, we're diving into a topic that can be an absolute nuisance in the field of patient care, managing skin reactions caused by cancer treatments. Now, if you spent any time at all in an oncology ward or a clinic, you'll know that skin reactions are incredibly common. They can range from mild irritations to severe complications that seriously impact the patient's quality of life. And let's be honest, as healthcare professionals, we want to do everything we can to make our patients' journey on this cancer timeline as comfortable as possible. So whether you're a budding hematologist or oncologist, just starting your career, or a seasoned pro looking for a quick refresher, this episode is for you. We're going to break down the most common skin reactions, why they happen, and most importantly, how to prevent and manage them. So let's start with one of the most frequent culprits, acneiform rash. Picture this, your patient starts a new targeted therapy and within days or weeks, they develop an acne-like breakout. It's not just a cosmetic issue, it can be itchy, painful, and even affect their self-esteem. The good news is we have a few tricks up our sleeves to tackle this. So, acneiform rash is most commonly seen with drugs that target the epidermal growth factor receptor, EGFR, so drugs such as erlotinib, afatinib, and cetuximab. It's also a frequent side effect of MEK inhibitors, which are used in melanoma treatment. Trametinib is one of those. We're talking about 75 to 90% of patients developing this rash, with about 10 to 20% experiencing a more severe form. The occurrence and severity of the rash have been linked to a positive response to therapy in some cases. Actually, exhibiting the rash can mean that you're responding positively to therapy. This rash isn't your typical teenage acne. It usually starts on the face, particularly the forehead, nose, and cheeks, and can spread to the scalp, chest, and upper back. It's characterized by papules and pustules, which are small raised bumps that may contain pus. Patients often experience itching, stinging, or pain. Now, let's get a little bit nerdy and talk about underlying cause. These medications disrupt the normal function of skin cells, leading to inflammation. Think of it like a domino effect. The drug interferes with the EGFR or MEK pathways, which in turn triggers a cascade of events that result in the recruitment of inflammatory cells to the skin. The inflammation is what causes the rash. To make matters worse, these medications can also weaken the skin's natural defenses, making it more susceptible to bacterial infections. So in some cases, the rash can become super infected, which means it's not just inflammation we're dealing with, but also a bacterial party on the skin. So how do we manage acneiform rash? Well, prevention is always better than cure, right? So before starting these medications, we can advise patients to take proactive measures to protect their skin. This includes moisturizing regularly with alcohol-free products to keep the skin hydrated and prevent dryness, which can exacerbate the rash. Using gentle comedogenic, that's a tough word to say, skincare products that won't clog pores. Avoiding harsh soaps, scrubs, and other irritants that can further inflame the skin, and protecting the skin from the sun with sun cream, as sun exposure can worsen the rash. In addition to these skincare measures, we can also consider prescribing oral antibiotics like doxycycline or minocycline. These antibiotics not only help prevent infections, but also have anti-inflammatory effects that can help reduce the severity of the rash. If the rash does develop, we can step up our game with the following treatments. Topical steroids. These can help reduce inflammation and soothe the skin. We can start with low or moderate potency steroids and escalate to stronger ones if needed. Oral antibiotics. If the rash is severe or shows signs of infection, we might need to continue or initiate oral antibiotics. And then oral steroids as well. In the most severe cases, a short course of oral steroids like prednisone can be very effective in reducing inflammation or promoting healing. So what are the recommendations? It's that prevention and treatment. So prevention, moisturize regularly, use gentle skincare, avoid irritants, use sunscreen, and consider oral antibiotics if necessary. And treatment, topical steroids, oral antibiotic, and oral steroids severe cases. Remember, early intervention is key. The sooner we address the rash, the better the outcome for our patients. By taking a proactive and comprehensive approach to prevention and management, we can help our patients navigate this common side effect and improve their overall quality of life during cancer treatment. So now let's move on from that, and we'll talk about another skin reaction that can really put a damper on patients' quality of life, and that's hand-foot syndrome, or HFS. It's also known as palmar-plantar erythrodysesthesia syndrome, or PPES, but let's stick with HFS or hand-foot syndrome for simplicity. This condition can cause redness, swelling, tingling, and even painful blisters on the hands and feet. Imagine trying to walk or even hold a cup of tea with that discomfort. It's no wonder this can significantly disrupt the patient's daily activities. So hand-foot syndrome is a common side effect of certain chemotherapy drugs, particularly those containing 5-fluorouracil or capecitabine. It's also seen with targeted therapies like sorafenib, sunitinib, and regorafenib. The incidence varies depending on the specific drug and the dosage, but it's not uncommon to see it in a significant proportion of patients receiving these treatments. In fact, some studies have reported hand-foot syndrome in up to 60% of patients on capecitabine and 50% on regorafenib. So hand-foot syndrome typically develops within days to weeks of starting treatment, but in some cases it can take up to 6 months to appear. It usually begins with a tingling or burning sensation in the palms of the hands and soles of the feet. This can progress to redness, swelling, and even blisters. In severe cases, the skin can crack, peel, and become very painful. Now, what's happening under the skin? Well, the exact mechanism of hand-foot syndrome isn't fully understood, but it's thought to involve damage to the small blood vessels in the hands and feet. This damage leads to inflammation and the release of substances that cause pain and other symptoms. Again, similarly to acneiform rash, prevention is key. We can advise patients to moisturize, regularly applying moisturizing creams, especially those containing urea, can help the skin hydrated and less prone to damage. Avoid friction and pressure, so wearing comfortable shoes and gloves, avoiding long walks or runs, and using padded insoles can help reduce friction and pressure on the hands and feet. Also, protect from heat. Avoiding hot water, saunas, and other sources of heat can also prevent hand-foot syndrome. Hand-foot syndrome does develop, and we then have several treatment options. So we have topical corticosteroids, which can help reduce the inflammation and relieve pain. We have pain relievers as well, so over-the-counter pain relievers like paracetamol or ibuprofen can help manage mild to moderate pain. Keratolytics, these medications such as salicylic acid or urea can help soften and remove thickened skin. And cooling. For some chemotherapy drugs, cooling the hands and feet during infusions can help prevent or reduce the severity of hand-foot syndrome. In severe cases, we might need to adjust the dosage of the cancer treatment or even temporarily interrupt it until the hand-foot syndrome improves. Back to those recommendations: prevention and treatment. Prevention: moisturize regularly, avoid friction and pressure, protect from heat. Treatment: topical corticosteroids, pain relievers, keratolytics, cooling for certain chemo drugs. And again, remember, early intervention is key. We can help our patients tip on through their treatment with minimal disruption and improve their overall quality of life by getting those early interventions. Now let's talk about a side effect that's often dreaded by patients: hair loss or alopecia. It's not just about vanity, it can be a major blow to a patient's self-esteem and emotional well-being. Chemotherapy-induced alopecia is a well-known side effect, affecting up to 65% of patients receiving chemotherapy. The severity can vary depending on the type and dose of chemotherapy, but it's a common concern for many patients. While not as widely discussed, endocrine therapy-induced alopecia is also a reality for some patients, particularly those on aromatase inhibitors. Studies suggest it affects around 4.4% of patients, but is likely underreported due to its less severe nature. Chemotherapy-induced alopecia typically rears its head 1 to 3 weeks after starting chemotherapy. It usually results in diffuse hair loss across the entire scalp, but it can also affect eyebrows, eyelashes, and body hair. The hair loss process is quite rapid as chemotherapy damages hair follicles in their active growth phase. On the other hand, endocrine-induced alopecia is a slower process, often taking 6 to 18 months to become noticeable. It primarily affects the crown of the scalp and is characterized by gradual thinning of the hair. This is due to the endocrine therapy causing hair follicles to shrink and enter a resting phase. Now, for the million-dollar question, can we prevent or reverse hair loss caused by cancer treatments? The answer is, it depends. So for chemotherapy-induced alopecia, scalp cooling has emerged as a promising preventative measure. It involves cooling the scalp before, during, and after chemotherapy infusions to reduce blood flow to the hair follicles, thereby minimizing drug exposure. Studies have shown that scalp cooling can be quite effective, with 50 to 65% of patients experiencing only minimal hair loss. However, it's not suitable for everyone, and there are some contraindications to be aware of, such as hematological malignancies and cold sensitivity. Unfortunately, there's no magic bullet for preventing or reversing endocrine-induced alopecia. However, we can offer supportive care to patients to cope with the hair loss. This includes providing information about wigs, hair pieces, and head coverings, as well as addressing any underlying nutritional deficiencies that might contribute to hair loss. So, back to our recommendations: prevention and management. So, prevention of chemotherapy-induced alopecia, scalp cooling is the most effective preventative measure. And management of the two: supportive care, including wigs, hair pieces, and head coverings. Address any nutritional deficiencies such as iron, vitamin D, or zinc deficiency. While hair loss can be a distressing side effect, it's important to remember that it's usually temporary. Most patients experience hair regrowth within a few months of completing chemotherapy. And for those on endocrine therapy, the hair loss is often less severe and may even improve over time. Remember, open communication with your patients is key. Discuss the possibility of hair loss before starting treatment, offer support and resources, and help them explore options for managing this challenging side effect. Use guides like the Irish Cancer Society or any local cancer support services to help you out with this. Now let's move on again and talk about another skin reaction that can be incredibly frustrating for patients: drug-induced pruritus, or in its simpler terms, itching caused by cancer treatments. It's like a persistent itch that just won't go away, and it can seriously affect the patient's sleep, mood, and overall quality of life. Drug-induced pruritus is a common side effect of many cancer treatments, particularly targeted therapies like EGFR inhibitors and immunotherapies like PD-1 inhibitors. The incidence can vary depending on the specific drug, but it's not uncommon to see it in a significant proportion of patients. For example, studies have shown that a high-grade pruritus can often occur in up to 1.8% of patients on EGFR inhibitors and 13.67% of patients on PD-1 inhibitors. Diagnosing drug-induced pruritus involves a thorough patient history and physical exam. We need to rule out other potential causes of itching, such as allergies or underlying skin conditions. It's also important to assess the severity of the pruritus, as this will guide our treatment approach. We can use various scales to measure the intensity of the itch, like the Visual Analog Scale, VAS, where patients rate their itch on a scale of 0 to 10, or the Numeric Rating Scale, which is similar but uses a scale of 0 to 100. The good news is we have a range of options for managing drug-induced pruritus. The approach often depends on the severity of the itch. So, mild pruritus. For mild cases, simple measures like moisturizing regularly can help soothe the skin and reduce itching. We can also recommend over-the-counter anti-itch creams containing menthol or pramoxine. Then we have moderate pruritus. If the itching is more bothersome, we can prescribe topical corticosteroids which have anti-inflammatory properties. Oral antihistamines like loratadine or cetirizine can also be helpful, especially if the itch is associated with an allergic reaction. And then you have severe pruritus. In severe cases where itching is constant and significantly impacts the patient's quality of life, we might need to bring out the big guns. This could involve medications like the gabapentin or pregabalin, which are typically used for nerve pain but can also be effective for itch. In some cases, we might even consider a short course of oral corticosteroids. So again, looking at our recommendations here: prevention, moisturize regularly and avoid known triggers of itching. Mild to moderate pruritus, you look at your topical corticosteroids and your oral antihistamines. And in severe pruritus, you're looking at gabapentin or pregabalin or oral corticosteroids. It's important to note that these are just general recommendations, and the best approach will vary depending on the individual patient and the specific medication causing pruritus. So let's move on to another common skin reaction here now: paronychia, or inflammation around the nails. It's not just an annoyance, it can be painful and even lead to infection. Imagine trying to button a shirt or tie your shoelaces with sore, swollen fingers or toes. That's no crack, and it can really interfere with a patient's daily life. So paronychia is often seen with EGFR inhibitors like cetuximab and erlotinib. It can also occur with other targeted therapies like MEK and mTOR inhibitors, and less commonly with chemotherapy, particularly taxanes. Studies estimate that all grave periungual lesions occur in about 17.2% of patients on EGFR inhibitors, with severe cases being less frequent. Paronychia usually develops gradually over weeks of treatment. It often starts as redness, swelling, and tenderness around the nail fold, which is the skin that borders the nail. It can progress to the formation of granulation tissue, which looks like a little lump of flesh. And in some cases, bacteria or fungi can invade the area, leading to a secondary infection with pus and discharge. The exact cause of paronychia isn't fully understood, but it's thought to be related to the way these medications affect the growth and function of skin cells around the nails. The skin becomes thinner and more prone to damage, allowing bacteria and fungi to enter and cause infection. Again, this is paramount across all of these guys, but prevention is key. We can educate our patients on proper nail care, such as keeping your nails clean and trimmed, avoiding trauma to the nails like biting or picking, moisturizing the cuticles and surrounding skin regularly, wearing gloves when doing household chores, and avoiding excessive moisture. If this condition does develop, we have several treatment options, again, depending on the severity. So in mild cases, we can recommend topical antiseptics like povidone iodine and topical corticosteroids to reduce inflammation. In moderate cases, and if there's evidence of infection, we'll need to add topical or oral antibiotics to the mix. And in severe cases there where the pain is significant or the infection is spreading, we might need to remove part of the nail to allow for proper drainage and healing. So look at those summary recommendations again. Prevention: educate patients on proper nail care, moisturize regularly, and avoid trauma. In mild cases, you're looking at topical antiseptics and topical corticosteroids. In moderate cases, you need topical or oral antibiotics. And in severe cases, you might need a partial nail removal and further antibiotics. Okay, so let's wrap up our discussion here with another nail-related side effect: onycholysis or onycholysis, whatever your pronunciation is. This is a condition where the nail plate separates from the nail bed, and it's a common side effect of taxane chemotherapy drugs like docetaxel and paclitaxel. So taxane-induced onycholysis is very common, affecting up to 43.7% of patients treated with paclitaxel and 34.9% of those treated with docetaxel. It's one of the most prevalent adverse events associated with these drugs. While mild to moderate onycholysis can occur with other chemotherapy agents and some targeted therapies, severe cases are almost exclusively seen with taxanes. Onycholysis usually becomes noticeable a few weeks after starting taxane treatment. The nails, particularly the fingernails, become discolored, often turning black, white, or brown red. The nail plate starts to lift away from the nail bed, creating a space that can collect debris and become infected. This can lead to pain, discomfort, and even the loss of the nail. The exact cause of taxane-induced onycholysis isn't fully understood, but it's thought to be related to the drug's toxic effects on the nail bed. Taxanes can damage the cells that make up the nail bed, leading to inflammation and separation of the nail plate. So, how do we manage this? Well, we can advise patients to, again, moisturize, regularly applying emollients to the nails and cuticles can help keep them hydrated and less prone to damage. We can protect them by using protective nail lacquers that can create a barrier against external irritants and help prevent the nails from drying out. Again, avoid trauma. Patients should avoid activities that could injure the nails, such as using them as tools or biting them. And cooling. For some patients, cooling the hands and feet with frozen gloves or socks during chemotherapy infusions can help prevent or reduce the severity of oncolysis. If onycholysis does occur, we can manage it with nail care, so keeping the nails clean and trimmed can help prevent infections. Antibiotics, if an infection does develop, we'll need to treat it with topical or oral antibiotics, and then nail removals. In severe cases where the nail is causing significant pain or is infected, we might need to remove it to allow for proper healing altogether. Again, our summary recommendations of prevention and treatment: prevent, moisturize, protect the nails, avoid trauma, consider using cooling hands and feet during chemotherapy. And treatment: that nail care, again, making sure they're nice and trimmed, products if needed, and nail removal in the most severe of cases. By educating our patients about onycholysis and taking steps to prevent and manage it, we can help minimize the impact of this common side effect and improve their overall experience during their cancer treatment. So there you have it, a whirlwind tour of common skin reactions caused by cancer treatments. We've covered acneiform rash, hand-foot syndrome, hair loss, drug-induced pruritus, paronychia, and onycholysis. These reactions can be a real challenge for patients, but with the right knowledge and strategies, we can manage them as effectively as we can and minimize their impact on patients' quality of life. And as I reiterated through this entire podcast episode, early intervention is key. By addressing and identifying these skin reactions early, we can often prevent them from worsening and causing unnecessary discomfort for our patients. And even when the reactions do occur, there are a variety of treatment options available that can provide relief and support. I suppose by having open and honest conversations with our patients about what to expect, we can help them feel more prepared and empowered to manage these challenges ahead. So thank you as always for listening to this episode of the Irish Haematology Oncology Podcast. If you enjoyed this episode, please share it with your colleagues and subscribe to this podcast for future episodes. Please leave us a review on Spotify and Apple Podcasts, which helps others discover the show. And if you have any questions or topics, or you have any guests that you'd like me to appear on the show, please don't hesitate to get in touch through our social media channels at Irish Heme Onc Pod on Instagram, or emailing us on the Irish Heme Onc Podcast at gmail.com. Or, as always, through our feedback form in the show notes below. And as always, I'll end on this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer is always advancing, and new research may lead to changes in treatment approaches and safety protocols. Always consult with your healthcare providers for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. Okay, until next week.